As the drug overdose epidemic claims the lives of Minnesotans across the state, new synthetic substances like fentanyl and xylazine continue to contaminate the drug market. To decrease the risk of overdose, people who use drugs can access take-home test strips, which can identify specific substances in their drug samples before they use them, empowering people to make safer choices. In 2023, the Minnesota legislature legalized all drug checking equipment for public use, including more sophisticated FTIR machines, which harm reduction organizations may use to provide more accurate information on drug samples to community members in just minutes. But for medical providers and law enforcement across the state, the best place to learn about the drug supply in their local communities is at the state-of-the-art Public Health Lab of the Minnesota Department of Health, which has been testing drug samples for years and continues to expand its monitoring of emerging health threats with innovative partnerships that bring data to action and save lives.
Most people these days, when you think of the Department of Health, are initially thinking of COVID testing. Outside of that, we try to provide a very comprehensive data set on any types of public health threats or emergencies that might pop up. And that could be outbreaks of salmonella poisoning, right? They'll have epidemiologists to track the exposures there. And then we're doing the same thing for overdoses with drugs. We are testing clinical samples, so that's urine, whole blood, plasma or serum, and physical product samples for the presence of up to roughly 1,100 different substances right now.
We offer information of what we are actually seeing and the various changes within a drug supply. We have seen some xylazine samples.
We first detected it in our samples in December of 2020. And since then, we've had periodic detections totaling between 1 and 3 detections per month, usually. And some months there's none. And so it's really interesting to think about what's being covered in the media and what we're seeing.
So we have MNDOSA and MNTest. MNDOSA is our clinical samples. So those are patient samples coming from emergency departments. With our MNTest samples, those are our solid or product samples. The extraction is a little bit different because it'll depend on whether or not we get a pill and have to crush it up, or if we get a liquid that's unknown.
MNDOSA is our Minnesota drug overdose and substance use surveillance activity.
Hospitals routinely send samples off for confirmation testing, and the best outcome they get is more and better data for their patients.
MNDOSA, in essence, is a way to capture the impact of substance misuse on emergency departments in Minnesota. But we're also able to look at what clinicians believe or suspect that a person's been exposed to and compare that to what, in fact, shows up in toxicology.
My patients love to tell me what they're taking. And I think that most of us know that our patients really know all the things they're taking and probably don't know what it is actually they're taking. This has, at least for me, provided the opportunity to talk to my patients about objective data that squares that away.
It really is very powerful, I think, to be able to say to somebody, gee, you don't know what you're getting. Here we have confirmation that these substances are in our community. Getting to talk to patients and their families and the folks who come in with them to share this information is just amazing.
And then MNTest, instead of just looking at the clinical samples, which we get from MNDOSA, we are looking at the physical product samples. So we're able to test substances provided by local law enforcement for the presence of the drugs in them. So these are substances that were part of maybe an overdose event, but are not part of a chargeable case.
Knowing and understanding what folks might be using has been helpful for them to understand how dangerous it is and ultimately what sort of resources exist. We're bringing something to the table to say, listen to what we learned from the Public Health Lab, so that when we're looking to treat individuals, that we're as educated on the topic as we can be.
So once our samples arrive at the Public Health Lab, we'll bring them into this freezer, organize everything. Then we'll add our samples to the extraction plate. Once that happens, we'll add a series of chemicals. Then we'll move them onto our biomech, which is our pipetting robot. And that will essentially isolate the drugs of interest out of the blood and urine.
And then we'll shake it up. So we'll pulse it, and then we'll just shake it completely. If you wait too long, the blood can clot. So You don't want to act too slow.
The next step after this is to concentrate the samples down to allow our instrument the best chance of seeing the drugs that are present. So we would hit go, and then it just does this until the samples have been dried down. So we'll put our plate in this little compartment. It'll take a very small sample. It'll run it down through this system. Sample goes through the column. It gets plumbed through here and then goes into the source. This is, I think, the coolest part for me as a chemist because you get to see in real time what the instrument is seeing. So we're definitely seeing some signal right now. These are true ions, true masses, true compounds hitting the detector. So we know that drugs, chemicals, compounds, everything in the universe is made up of atoms connected in different places. Each drug has a specific molecular weight. So if you count up how much each of those atoms weighs, it's unique. It'll basically isolate a drug, fentanyl, let's say, and then it'll collide it with helium atoms, which will break it apart. And the fragments will then all add up to the parent mass of fentanyl. Essentially what we get at the end is like a fingerprint for each drug. It's like a snapshot of what was taken and what potentially caused an overdose.
Communicating the whole process is tricky. We're using really high resolution instrumentation that I think can be a challenge for even some chemists to understand.
So if you think of the analysis we're doing as if you look at a cookie and you have all these different components that go into bake a cookie, sugar is going to be a molecule that you'll find in that. And so we are taking apart all the pieces, the flour, the chocolate chips, the raisins, anything else in there. We're taking all that stuff out so that we're just seeing that sugar. That's what we're looking at there. We're trying to find the drug.
There's chocolate chips could be clustered in one area of that cookie and none in another of the same cookie. And that's the same thing with drugs in pills or powders. Portions of them are just not going to have the substance. So when you have a test strip, a fentanyl test strip, they could miss something that's there due to the fact that you didn't sample the right spot. When we test those substances, we tend to mix them up quite a bit, and we take a larger portion of it to give us a better chance of identifying anything that's present.
We've talked about the toxicology testing. We also collect clinical data that gives us a better picture of who are most impacted by substance use and overdose. What are the circumstances around the event that brought them in, or the symptoms that they're experiencing?
For example, the type of location from which the patient comes. Did they come from home? Did they come from a homeless encampment because they're unstably housed?
The identification of somebody who has unstable housing. What is it? What are the other couple of questions can I ask them? What can I do to help with follow-up to find out who may be at increased risk?
And the reason that's important is even though it's not identifiable, no identifiable data goes anywhere. I get feedback from Deepa and her team when we get 3 or 4 or 5 patients for whom we've sent samples because they're atypical. And it turns out, for example, they all come from an encampment and they all have a very similar fingerprint to their testing. And it's helpful for us to know whether there might be what you might colloquially call a bad batch, or at least a new batch that's circulating in our community.
These sort of cluster investigations, when we've looked more closely at patients who might be seen on different shifts and may come in separately, but are somehow linked based on their exposures or circumstances, which helps us understand better, how interventions can be designed to impact those folks.
At times, I'm following up with the family members who know that their loved one has been struggling and want to know how they can help them. Real information is what matters in those moments when we're trying to find strategies for intervention and prevention of death. Being able to share in real time some of this information that the Public Health Lab has provided to our law enforcement has been really, really helpful.
One of the high points for me is the opportunity to check in as a group and review data together and actually converse about our current lived experience with respect to our patients. That's useful. That gets me thinking clinically in a way that I wouldn't otherwise. The closest that we've been able to get to seeing what is in our community comes from our involvement in MNDOSA, where if something looks different, I'm able to flag it. And if there are any biological samples left over, we can just send it over to our colleagues at the Department of Health, de-identified, and in a period of a month or so, at least get an idea of what's floating around in our community. I'm compelled to say that I think this was a really positive program for our hospital, and I think it would be for others that were willing to join. And I think that the value to our community is undeniable.
Somebody like me, who I think has less experience and knowledge from a public health standpoint, any time that public health can be involved, it's a plus. You know, to be able to, as Travis said, just pick up the phone and talk, whether it's MNDOSA or another question. Those partnerships are invaluable.
Partnerships are absolutely crucial to the work we do because we depend on the insight we get from our colleagues who are working on the front lines of the overdose crisis to tell us about trends and changes and emerging concerns. So we collect all the data, but we have to be able to understand what it means and what the impact, the real world impact is.
Knowledge is power. And when we have this information, we can use it to our advantage to help individuals that are really struggling.
Most states don't have funding available to do this. And I think that's what's pushed Minnesota's program kind of to the forefront nationally. State funding that was just passed at the legislature really keeps our program stable over the next 2 years and keeps a good service in place.
As we're able to onboard new hospital sites in different regions of the state, we hope to be able to build a more customizable prevention platform.
We envision MNDOSA to operate in some ways like an alert and response system. So as different regions are seeing new trends and emerging substances in their communities and sharing that information across the state to inform local responses for outbreaks of emerging substances or spikes in overdoses. So there's a lot of potential for expanding and a lot more to be gained with additional partners.
What we can do by bringing all of this data together is bridge that gap, form that connection between what substances are present, what symptoms clinicians are seeing, and then they can make a treatment plan that's best to help avoid overdose deaths in the future.